So, good morning, everybody. We'll go ahead and get started. We have material up at the front. If you guys want to take anything, I believe that Brooke and Laurie will be going over some of those handouts. If you don't get them now, get them on your way out. And there's some other literature up there. If you need a bathroom, go out the door to the left, and they're on the left. And this is being recorded, not your actual, not a screen of you, but your voices. So just keep that in mind. But we have Brooke Tyson with us today. She's the Community Services Educator with the Gainesville Memory Assessment Clinic. She holds a bachelor's in both psychology and gerontology. Her role as the CSE is to meet with family and or friends to capture detailed information regarding patients with memory loss. Her goal is to get the full picture of any concern so that they can provide the most accurate diagnosis and resources. She connects families to educational community resources as well as develops a care plan for specific needs and goals moving forward. The Gainesville MAC is partnered with the Georgia Memory Net managed by Emory University. We also have Laurie Beth Bryant. She is the Associate Program Director with the Georgia Memory Net out of Emory Brain Health Center. She began her career in the criminal justice field and later pursued a master's degree in clinical mental health and rehab, graduating from Thomas University in 2016. Her professional journey led her to discover a passion for working with older adults. Laurie worked several years as the ADRC director at Sewega Council on Aging, the area agency on aging of Southwest Georgia, before transitioning to the Memory Assessment Clinic in Albany, Georgia, as a community service educator. In 2020, Laurie joined the Georgia Memory Net Central team and currently holds the position of Associate Program Director for the Community Services Core Team, where she demonstrates her dedication to supporting individuals with dementia and their caregivers. You just put it right here. Okay.
All right. Hey, everybody. My name is Brooke. I'm the Community Services Educator with Northeast Georgia. And today we're going to review a few different types of dementia and go over how our partnership with Georgia Memory Network can help families find resources and care for their families. Louder? So first, we'll go over a few of the different dementias. And one thing to remember is that there is a difference in normal aging and memory impairment versus cognitive impairment and aging. Normal aging and memory impairment could consist of like losing your keys and being able to find them, or forgetting to pay a bill and paying it, with a late fee every once in a while. While aging with cognitive impairment, you could lose your keys and not be able to find them, or forget to pay your bill several times and have several late fees. Dementia is an umbrella term for the different types of dementia. So dementia is like a general term for cognitive impairment, and that can affect our day-to-day activities, how we perform like house chores, paying bills, cooking, driving. All that is affected by our cognitive impairment and decline.
So let's just talk about how it's an umbrella term. Yeah. And it gets confused with Alzheimer's disease. The dementia is more of a symptom.
And dementia and Alzheimer's can be confused as well. Dementia is more of the umbrella term for different symptoms, while Alzheimer's, vascular dementia, and several other types are under the umbrella of what dementia is. Oh. Come on. Hello? Okay. Good. So Alzheimer's disease is the most common form of dementia. It makes up for 60 to 70% of dementia cases. It is not a normal part of aging. And Alzheimer's disease is caused by an abnormal buildup of amyloid plaques and tau proteins in our brain. Alzheimer's disease, these abnormal buildups in our brain can start to form in our brain a decade before we even experience or see any of these symptoms of memory impairment. Alzheimer's symptoms vary person to person. They can affect how we behave socially. It can affect our reasoning, our problem solving. It can affect, word finding, not being able to finish sentences, having people, help direct our thoughts. And it can also affect our vision. Alzheimer's disease can also have an early onset. It can appear in somebody's 30s to 60s. Frontal temporal dementia is one of the more rare forms of dementia. It usually appears in those under the age of 60. There isn't truly a known cause for what causes frontal temporal dementia, but if you do have family history of it, it can increase your likelihood of developing frontal temporal dementia. And there are tau proteins that build up in the brain that affect our frontal and temporal lobes. Our frontal and temporal lobes are responsible for how we multitask, how we plan. And in Alzheimer's dementia, there are amyloid plaques that build up in our brain that can also affect how we perceive and plan things. Frontal temporal dementia, like I mentioned, affects the front of the brain, like planning and multitasking. Some unusual behaviors in frontal temporal dementia is sometimes people can shout in public, like a public place like a library. They can also have an increase in sexual comments or behaviors. They could be rude to strangers in public. Emotional problems, they could not have empathy for how their actions or behaviors affect others. They may also have apathy or a decrease in motivation to complete everyday tasks, hygiene, trouble communicating. They may not begin to understand what people are trying to tell them or ask of them. They may have trouble reading, writing, or expressing themselves. And then there's also symptoms of stumbling, not much balance when you walk, and tremors. Lewy body dementia is the third most common dementia after Alzheimer's and vascular dementia. This one is caused by abnormal deposits of the brain known as Lewy body proteins. There are two different types of Lewy body dementia. There is dementia with Lewy bodies and Parkinson's dementia. Lewy body dementia is diagnosed when patients come in and their first symptoms are Memory impairment. Parkinson's dementia is usually diagnosed when the first symptoms are movement problems like tremors, balance problems while walking, and then later on memory impairment comes with Parkinson's dementia sometimes. Some symptoms with Lewy body dementia. The main ones are like hallucinations. People may see things that aren't there, hear things, or even smell things that aren't there. These hallucinations can often be dangerous. Like sometimes they may think someone's breaking into their house, or it can be, as simple as seeing a dog run by them. Or judgment, disorientation and confusion on where you may be. Movement, tremors, more falls. Sleep is also affected with Lewy body dementia. There is REM sleep disorder where people act out their dreams. They may yell, punch, kick. And then there's also behaviors of depression, agitation. People may pace back and forth. And then paranoia of people breaking in, stealing money, or accusing spouses of, cheating on them, whatever it may be that they are imagining. Vascular dementia is the last form of dementia that we'll go over today. This is the second most common form of dementia. This one is caused from damage to our blood vessels in our brain. So it could be caused from a stroke, brain bleeds, clots. It can also be caused by conditions that aren't maintained, like blood pressure, high blood pressure, high cholesterol, diabetes. And usually vascular dementia can be seen on an MRI where you can see a growth of white matter changes in the brain. It can be very mild to severe. They do say that if you are able to maintain these conditions like blood pressure, your thyroid, your cholesterol, that it can help prevent those memory problems from worsening, or could even make it better with time. Another thing that they suggest, neurologists suggest, having a nutritious diet. One that they recommend is the Mediterranean diet, consisting of fish, like salmon, blueberries, fruits, nuts. They even say dark chocolate. And they also recommend trying to add into your routine mental and physical exercises throughout your daily routine, like brain games, trying to join like community programs or like book clubs, and then trying to walk like 30 minutes a day. Some symptoms of vascular dementia. Performing tasks that used to be easy, so people may struggle with driving, getting to familiar places that they used to be able to get to easily. They may have trouble paying bills and not really be able to comprehend how to do so anymore. Difficulty following instructions, so they may struggle to follow previous cooking instructions that they used to be able to make a recipe really easily. If they used to work on like cars or vehicles, sometimes following instructions for that can be difficult as well. Misplacing items, misplacing glasses, car keys, sometimes like a hairbrush, and then not being able to find them. Insomnia is also a symptom of vascular dementia. Word finding and being able to finish sentences. And then lastly, some people experience depression, agitation, and anger. And then sometimes there can be cases of mixed dementia, and it's actually pretty common to see Alzheimer's and vascular dementia combined. This would mean that somebody has amyloid plaques in their brain as well as white matter changes. So they would have symptoms of both vascular and Alzheimer's. But then also with mixed dementia and vascular, you can try to maintain those conditions like we talked about, blood pressure, hypertension, and all that to kind of help control and keep your symptoms from worsening.
Thank you, Brooke. All right, so Brooke gave you all a very high level of various types of dementia. On all of our slides, we've got some links or videos that you can check out if you're more interested in a specific type of dementia or if your loved one has been diagnosed. I highly encourage you to learn more about that diagnosis so that you can better plan for your loved one. Does anybody have any questions regarding any of the dementias that we've gone over? I will be talking more about the Georgia Memory Net and how we all work together.
I have a question.
Yes. There are mostly for MCI, which is mild cognitive impairment, which we did not get into a lot of detail about. But we don't have a particular presentation on the treatment options for Alzheimer's disease or MCI today. But we can provide some of that information off of our website. Any other questions? Yes, that is our goal. So a lot of people have just a general diagnosis of dementia, and so we want to figure out, what is causing that symptom of dementia. So that is what our goal is, to figure out exactly what it's causing or what's causing the dementia, and then provide treatment options and support. All right, so let's first talk about the reality of Alzheimer's disease and related dementias nationally and as in Georgia. Really, it's a national crisis. 1 out of every 10 adults over the age of 65 is going to develop Alzheimer's disease. So that's actually a huge number. And it's even bigger in the state of Georgia. It's predicted that 26.7% of an increase by next year. Georgia will experience one of the largest percent increases on a national level. We'll talk about it in just a moment. So obviously, as I just mentioned, so people with Alzheimer's disease is growing. Again, just in Georgia, 190,000 individuals will have a diagnosis of Alzheimer's disease. There is 385,000 of self-reported cognitive impairment in the state of Georgia. 80% of those have yet to be evaluated or have mentioned this to their primary care provider. So people are experiencing symptoms but saying nothing about it. There's a 6-year average delay in memory loss diagnosis. Again, that's a big problem because the earlier you can get that diagnosis, the better, because treatment options are more effective in the earlier stages. There's $2 billion in preventable admissions to hospitals for undiagnosed Alzheimer's disease. So it's a big problem in the state of Georgia. So we've established the need, and so Georgia Memory Net was established back in 2018. So we are a statewide program dedicated to the early diagnosis and treatment of Alzheimer's disease and related dementia. And I highlight early diagnosis because we'll talk about, the reasons for that in just a few more minutes. But we are built by the state of Georgia and managed by Emory University School of Medicine, and we are funded by the Georgia Department of Human Services. And we have partnered with many academic institutions, community organizations, and professional associations and state networks, such as the Area Agency on Aging here. So we've got several goals in our program that I'll review, I guess the top three. Number one is to establish regional memory assessment clinics across the state so that we can improve Georgians' access to early and accurate diagnosis, and to improve long-term care and outcomes for those patients as well as their care partners. Second, we aim to improve primary care clinicians' screening, referrals to the memory assessment clinics, and care for Georgians with memory loss in a meaningful and sustainable manner. So we do a lot of primary care education, and we also train licensed clinical therapists and other professions so that they can properly work with this group of individuals. And then, of course, establish an oversight structure to monitor and evaluate project performance, continuing education, long-term patient outcomes, and GMN funds management to improve the care that all Georgians receive for dementing illnesses. So we provide oversight so that we can go back to the state and say, hey, this is really working in this area. We need more funds so that we can make it work across the state. So we collect a lot of data from our memory assessment clinics. Not the fun part, but it's needed and it's used wisely. So currently we have several locations across the state. We've got memory assessment clinics in Albany, Atlanta, Augusta, Macon, now in Gainesville, which is a recent opening, Savannah, and then Vidalia, Georgia. They should be opening, I'd say, within the next couple of months, hopefully. So these are all clinics where you can go in person for your assessment and diagnosis. We also have partnered with the Department of Public Health. So we have telehealth locations in Swainsboro, Vienna, Barnesville, Blairsville, Hartwell, and Dublin. We're working on, I believe, 3 more locations right now. So basically, if you are living in one of the rural areas, you do not have transportation to one of our 7 memory assessment clinics, and you don't have internet at home, you can go to a local DPH site and we can do a telehealth visit. So you can get your diagnosis and also your care plan, everything that you need, community resources at all of these sites. So it's been really awesome that we've been able to move to more of the rural areas for those that can't get to one of our sites. All right, so we'll talk about the GMN workflow. We have tried to design this for efficiency and convenience for all parties involved, PCPs, patients, care partners, as well as our community partners. So we try to work through a 2-visit model. That doesn't always work, but some folks need more testing before they can get a diagnosis. But for the most part, people come in for a 2-visit model. That first visit is their initial diagnostic assessment. I'll talk a little bit more about what that looks like in just a minute, but these appointments are typically about 3 hours long. So it's very detailed and thorough. It's a lot of testing because we want to make sure that we are providing that accurate diagnosis so that we can better support that patient and family. They'll come back for a second visit, and this is more about the conversation. The MAC provider will deliver that diagnosis, and then the CSE will talk with the care partner and that family on how to move forward with this new diagnosis. what are the goals moving forward after this diagnosis today? How can I help you on this journey? And then all of our patients are going to be referred back to their primary care provider. This is a 2-visit model, so they're not going to be coming back for a follow-up. So our MAC providers are providing the PCP with the diagnosis, the recommendation on how to move forward, and how to manage that patient. So the MAC provider will provide a detailed report with all of that information. They're available to answer any questions as far as the diagnosis and their recommendations moving forward. And then they're also going to be provided with a copy of the care plans and the coordination services with the Area Agency on Aging. So at the first MAC appointment, again, this is that really long appointment, but you can see there's a lot involved. So they're going to have their physical exam. The patient is going to have a physical exam with the provider. And I meant to mention earlier, we highly encourage all of our patients to come in with a care partner. It doesn't necessarily have to be a live-in care partner or someone providing, a whole lot of services or support to them. It could be a neighbor or friend, just someone who is able to confirm some of the symptoms and challenges that this patient is experiencing. So we want to hear from another source besides the patient. So they're going to go through, again, the physical exam, the neurological testing, and I'll show you what all tests we do. The CSE is going to conduct his or her assessments with the care partner. We do at least 3 assessments. We do the care needs assessment, the functional activities questionnaire, as well as the ZERIT caregiver burden. So the CSEs are trying to get a full picture of what is going on with that patient, care partner, and the family. So they spend a lot of time with the care partner. So as you can see, there's a lot of neurological testing. This can take a long time, considering the stage of the patient. But they do at least 13 neurological tests. Have those listed here. And these all test different parts of the brain so that we can get a good picture of what areas are being affected. After the first visit, most patients are going to get blood work, an MRI, and possible lumbar puncture. A lot of patients in the earlier stages will get a lumbar puncture to really confirm that diagnosis if it's unsure, if the MAC provider is unsure. So after their MRI, their labs, everything is kind of combined, the team is going to meet and come up with that diagnosis, and then the patient and the care partner will come back for that second visit. The provider will provide the diagnosis and talk about it. So it's not, you've got Alzheimer's disease, see you later, bye. They're going to have a very thorough appointment again. The CSE is there to develop a care plan. Again, like I mentioned, on plans moving forward, how can we help you on this new journey? He or she will do a care plan for the family. So the patient will get a care plan as well as the care partner and any other care partners that they bring. So he or she will address challenging behaviors, safety concerns, future planning, lifestyle modifications, things like that. And then, of course, make referrals to community partners. And then, of course, the patient is going to be transitioned back to their PCP for ongoing treatment. So one of my favorite parts about the Georgia Memory Net is our community service educators like Brooke. A lot of times when you go to the doctor and you get a diagnosis, you get the diagnosis and, your doctor's like, we'll start you on some medicine, but you really don't get to have a conversation after that. So the CSEs are there for that support, that education, and then connecting them with community support. So unfortunately, they're not case managers. with a 2-visit model, they're just not able to do that. So they are really more of that connection, that educator. And we rely heavily on our community partners for ongoing support. So what they do, of course, they do those standardized assessments. They create personalized care plans and then connect patients to community resources. Just an idea of what's all involved in the care plan that is going to our community partners and back to the PCP is all of their assessment results, patient needs summary, which is going to flag, major concerns, highlight major areas of need, and that initial plan. And then they'll also get a copy of the care plan so that everybody is on the same page moving forward, so that we're not duplicating services. And as mentioned earlier, we heavily rely on our community partners, especially the Area Agency on Aging and the Alzheimer's Association. So we connect our patients with the AAA so that they can get in-home services, get transportation, caregiver support like support groups or things like that, various services. All the AAAs have kind of different services, but for the most part, they're all able to help our patients. So let's talk about who is going to best benefit from a referral. As I mentioned earlier, so our appointments are very lengthy. So we're talking about a 3-hour first visit, possibly hour and a half, 2 hours at the second visit. So if you are thinking, if you have an 87-year-old individual that has maybe moderate stage dementia, that might not be the best person to bring in to do a 3-hour test. So, and the treatment plan would be quite different than someone coming in the earlier stage. So most likely to benefit from GMN is a patient with memory loss and an unclear diagnosis. Less likely, not saying that we do not ever see these patients, but less likely to benefit is a patient that already has a clear diagnosis of Alzheimer's disease or another dementia. Sometimes people do want a second opinion, and that's fine. We can see those people. Residents that are already in a skilled nursing facility, those patients are already being taken care of and really don't have any unmet needs. So community support would not be ideal for them. Patients that have a traumatic brain injury, and then patients that are younger than 50. Again, we do see patients younger than 50 because there are cases of early onset, but we do review the chart and make sure that it's a good candidate for the program. I like to review some of the educational opportunities that's offered by GMN. So actually, I'll just talk loud. Hold that just for a second. So at the front table, there's several flyers for opportunities for education. We've got our free dementia caregiver training through the Savvy Caregiver program. This is a 6-week evidence-based program for really teaching you how to master the caregiving role. So we like to think as becoming a caregiver as almost like a job, and so you wouldn't start a job without the proper training. So we provide that training through this 6-week course. It's free. So if you're interested, you can scan the QR code and we'll contact you to make sure you're appropriate for the program and get you signed up. I also included up front a little chart to talk, it kind of distinguishes the different stages. So these are some symptoms that someone with MCI would experience. And then it goes all the way to advanced dementia. So you can kind of figure out where someone is in their journey based on their symptoms. Information on the Cognitive Empowerment Program. You don't necessarily have to be a participant in this program to utilize their virtual online education opportunities. So this is mostly for folks with mild cognitive impairment as well as their care partner. They do a virtual session every week. Very informative, very helpful. And then we have, it's called What's Next? Practical Steps After Diagnosis. Topics include, MCI, dementia diagnosis, lifestyle tips, driving, staying safe, legal documents, advanced care planning, things like that. This is all covered in this link. It used to be a live session that we did every month, but we've recorded it so that it's easier for everybody to join at your own convenience. So very helpful information here. And then I don't have a flyer for it, but these are going to be on your slides. It's called the Dementia Lecture Webinar Series. This is the second Wednesday of every month at noon. You don't have to pre-register or anything. You can just click the link to join. But again, it's another series that we do for care partners and patients. But, if you have a new diagnosis, we have presentations like, advanced care planning, legal plans, things like that. Similar to What's Next, but it goes into a lot more detail about those particular topics. And then I talked about the CEP. I believe that's it. Oh, and then Brain Talk Live. Again, you can register using this link and look at previous recordings, but, virtual weekly sessions that's related to brain health, mild cognitive impairment, and dementia. So, my motto is the more you can learn, the better. We encourage folks to educate yourself as much as possible, just so that you can be prepared, because every person with a dementia diagnosis is going to be, they're going to have different challenges. They're going to have different behaviors. So the better you can prepare yourself for those challenges, the better off you'll be as a care partner. And avoid those unnecessary visits to the emergency room. So, all right, I believe that is all I have for today.